Okay, welcome everyone. Today we are excited to be talking about health equity and health disparity and some of the challenges that our patients and our patient community face in receiving equitable health care and equitable medical treatment. So for those I haven't met, my name is Chrissy Thornton. I am the Executive Director of the Myositis Association. I'm very excited to be speaking to you today about this topic. It has become, over the course of my career, pretty organic in my work to start to talk about diversity, equity, and inclusion alongside what I've been tasked to do. I obviously identify as a member of a community of color. And with that, I believe comes great responsibility for me to advocate for health equity for patients who may be receiving disparate treatment as they journey along with their chronic illnesses. And I am so super excited today to have with us a good friend of mine. We used to work together very, very many years ago, Jennifer Jacquet. I'm going to give her an opportunity to introduce herself really quickly, but I wanted to just say that I asked her specifically to join this conversation because she also represents various communities, but she has just a super insight into understanding this work and understanding how it affects people and understanding the privilege around health equity that I just thought we had to have her come today and you had to be able to hear from her as well. So I'll now allow or ask Jennifer to introduce herself to our listeners today.
Thank you, Chrissy. Hi, everybody. I'm Jennifer. I am a music therapist and a special education teacher. I am married to my wife, Kristen, and I have a son who is adopted and is Chinese. He was adopted in the United States, but he's Chinese. And I'm going to speak a little bit on the LGBTQIA community and why I, advocate for that community to get health equity and better healthcare outcomes. So I'm really excited to be here and have this conversation because sometimes these difficult conversations aren't had. They can be a little bit uncomfortable. So buckle up, get ready to hear some information that might be a little uncomfortable, but at the end, we're going to talk about ways to advocate for ourselves and also help others who are in these groups. So thank you so much, everybody, for being here.
Absolutely. So what I'm going to do is share our presentation and we can get started today with our conversation. And we'd love for you to begin pulling your questions together. We'll take the time at the end of the presentation to answer any questions that you might have, but please feel free to use the chat box or the question and answer box to pose questions to us at this time. Advancing health equity, a community conversation. I'm going to get started just by saying that, I feel very grateful to be positioned to lend my experience and my expertise in this area. We know here at the Myositis Association that we have a lot of work to do. Like most of our other partnering voluntary health agencies, the conversation around health equity, diversity, equity, inclusion is on the forefront. And we know that we have work to do in making acknowledgements and positioning ourselves to really be leaders in making sure that our patients, all of our patients, have the best experience as they journey through their disease processes. So I wanted to just give you some definitions. A lot of times we make assumptions while we're doing this work that people understand what the terms mean, what the acronyms mean. And so here we talk about the fact that many patients face obstacles around health equity and health disparity. Hopefully we all know and believe that to be true. If not, hopefully today during our conversation, we can give you some insight on that. And this talks about how racial, ethnic, religious, and other marginalized groups of people are disproportionately affected by preventable, and that is a key word to me, preventable disease and increased death and disability. And so here is a meme that most of you are likely very familiar with because it's been on Facebook and other social media mediums for years that depicts the difference between equality and equity. And when people see this, unfortunately, some people believe that this graphic has issues. They believe that this looks like giving just a little bit too much support and attention and a little bit too much help to people. And that is unfair. So this is to help you define the difference between equity and equality. So equality means you give everybody the same thing. right? And that makes assumptions, because if you believe that giving everybody the same thing creates equal access and equal experience, then that discounts the long history of longstanding suffering and discrimination and marginalization and disenfranchisement that different communities face. So giving everyone the same thing equally does not work in creating equity. When you are looking at equity, you're looking at giving everyone what they need. And so that is a difference we wanted to point out today. But at the same time, knowing that ultimately our goal is liberation. And that means that, we know it's a long road. We know it's a lot of work to get to where we need to be as a community, as a society. But ultimately, the goal is to remove the barriers that are systemic and that exist, that create these inequities for people, and to really level the playing field. And so I like to talk about equality and equity, but to remind people that ultimately where we really want to get to is liberation. And we believe, leaders in this work believe, that it is possible. We know it will take time, but we believe that if we are relentless in our pursuit of health equity and in tackling the issues, and if we are relentless in being willing to have the conversations, that it is possible. Health equity is achieved when everyone has the opportunity to attain. So everyone, right? We don't want people to be disadvantaged from achieving potential because of their social positions or other socially determined circumstances. You'll hear a lot right now. It's a super hot button topic to talk about diversity, equity, inclusion, or DEI. And that is not just about racism. The mere mention of racism really scares people in a way that stops them from having the powerful conversations that need to be had to make sure that this work is done. Not just racism, homophobia, or any other exclusionary term. It just scares people because we don't want to be classified as a group of people that are discriminatory, or as a group of people that contribute to the leaving out of others, right? But there's a little bit of acknowledgement that has to happen in all of our conscience to be able to successfully move the dial forward. So this says that health inequities are reflected in differences in length of life, quality of life, rates of disease, disability, and death, severity, and access to treatment. So can you imagine, and many of you who are tuning in may be able to, can you imagine your length of life, okay, your severity of disease, and your access to treatment being altered simply by who you are? Simply by who you are. Something that you have no determining control over, just who you are, resulting in increased, tragedy medically in your life. And so what we want to talk about is not just the isms. We want to talk about access, and we want to talk about experience. This transcends, the racisms, the homophobia, the thisism, ageism, or whatever. It goes deeper, and it talks about really what are the lived experiences of people. And if you don't identify with one of these communities, it's great that you're here, because we can help inform you about some of the experiences that maybe you're not even aware of, that people who are members of other communities face in their healthcare journey. And so this says, and I think this applies to everyone, right, that visiting a healthcare provider requires vulnerability. We all know that, right? You have to discuss your body. You have to discuss your mental health. You have to share, a lot of times, intimately personal details. That alone dissuades many people from getting medical treatment. That alone, right? That level of having to be vulnerable. A lot of times people choose to suffer in silence. But add to that an experience where you feel healthcare professionals aren't listening to you, specifically because they don't identify with you, right? Add to that they are being dismissive to your questions and brushing off your concerns, right? And this is a reality for many patients who are members of communities that aren't considered traditional and normalized, okay? And what we know is that people don't get into the medical career, people don't get into the medical field, which is filled with servant leaders, to be discriminatory. They don't get into the medical field to be harmful. They don't get into the medical field to leave people out and to be dismissive. But what happens is our human nature, right? And what we innately are taught as we grow in society seeps into everything we do. It seeps into my work in nonprofit management. It seeps into the work of people who are healthcare professionals. And then your judgments start to affect how you relate to other people. It is sometimes the most subconscious thing It's not necessarily intentional. I would venture to say that in some cases it can be, but it's not always intentional. Medical professionals are, by the nature of what they've signed up to do, there to help people, right? They are people who have decided they want to help other people, but just who we are in our human nature sometimes causes us to fall short. So this says that these people and more, people that fall into these groups and others, face health disparities that are linked to stigmas, societal stigmas, discrimination, and denial of their civil and human rights. We have to acknowledge that, okay? Here's a quote from the Chief Diversity Officer at the University of Washington Medical School of Medicine. Okay, this acknowledges healthcare disparities and biases, right? They're part of just the, the inequities that exist in society. So we can't believe that our society is flawed, that in society people face discrimination, that people face exclusion, that people face, harmful treatment, and people face being marginalized. We can't believe that and then believe suddenly that when we go into the healthcare setting, that all of that just goes away, right? And everyone has the same experience. So this says it boils down to certain groups receiving more benefits than others, and that is historic and present today. I love that, right? Because this isn't new. This isn't new. The conversations are just starting to emerge in a way that's powerful and that are solution oriented. And this has everything to do with privilege, which we'll talk about a little bit more. So unconscious bias, this is terminology you'll also hear in this work. It is unintentional stereotyping, okay? We are all holders of unconscious bias. No one is exempt from it, okay? You can, in your learning and your willingness to expose yourself to other cultures, communities, types of people, you can start to combat your unconscious bias, but we are all holders of unintentional stereotyping. And unfortunately, it can lead to the holding of false beliefs, even in the medical field, right? Bias means that some people will end up having subpar treatment, right, for what are normally very treatable conditions. And this can in turn lead to catastrophe medically. It can lead to inadequate care and real health consequences. Okay, so I'm here today because I told you I identify with a community of color. I identify as an African-American woman. And because of that, I have membership as a person of color. And it gives me not only the right and the experience and the perspective, but it gives me the responsibility to help educate what I know about my own community. So today, I'm here to talk, and Jen is here. We're here to talk where we feel like we're best suited to speak. And so I would like to just talk very briefly about some challenges that people of color traditionally face in healthcare settings. BIPOC, okay? A lot of people are like, what is that? So BIPOC, it is a fairly new term. It originated about 2018 and 19. It's used pretty commonly now, and it stands for Black, Indigenous People of Color, okay? And this relates and highlights the unique relationship that Black people and US Black people specifically, so United States Black people and Indigenous people have to white supremacy. So it's not just being melanated. There are plenty of melanated people that don't have the African-American experience, but BIPOC really points out that Indigenous people and Black people originating, Black people in the United States have a increased experience with white supremacy. And so this term is one that you'll see being used in this work. So this says that BIPOC people have an increased tendency to shelve their health. What does that mean? I mean, that is something that, if it's true, should definitely be considered. So why? And here's where we get to talk about privilege. And I love hearing Jennifer talk about it even more than me, but I love talking about privilege because it's so eye-opening, right? Because as soon as you feel like you lack privilege, there's someone else that can point out how much privilege you in fact do have. And so in this instance, where it says people of color have an increased tendency to shelve health, it is because life is hard for everyone. I love that. I love that acknowledgement. So I don't care what community you belong to or what your who you are innately or what you've experienced. Everyone has ups and downs. Everyone has challenges, and we acknowledge that. But life is a little bit harder for people in our myositis community, of course, because you're living with a chronic illness. Okay, so right there, life becomes harder. But what additional crises are people in our patient community right? What additional crises do patients of color specifically experience that disrupts their ability and their privilege to prioritize their health? And so this is a challenge we have to acknowledge and we have to integrate into our solution-oriented work, right? Where we as an organization are looking at how to help patients and we're looking to find solutions. We have to understand what the patient walks in with, right? Okay, it's a patient who's living life, so there's already a significant amount of challenges that are being faced. It's a patient now that's living with a possibly rare disease, myositis, incurable chronic illness, okay? And then now what is on top of that? And so when we look at the past year, all of us have lived through this global pandemic, and it's been, I would challenge anyone to say that it's been difficult for everyone, right? But there are other people who, in addition to the global pandemic, have had to deal with economic crisis, right? Whether they've lost their job, they were already underemployed, they've had situations maintaining their income or their income levels have decreased because of societal changes. Many people, even affluent people, suffered greatly over the past 2 years, specifically in the beginning of the pandemic, by losing retirement funds and losing investment funds. And so there are some subset of our community that also have dealt with economic challenges. And then add on top of that, if you are someone who has dealt with the racial injustice that has really taken over our society, specifically in the past couple of years. Imagine throwing the stress of that on top of your situation. And then you can start to understand why some people have less privilege to prioritize their health. Okay. There are also stigmas in community of color that lead patients to choose between faith and care. I'll tell you, in the African American community, there's a tradition that if it's something horrible going on in your life, that your family and your friends and the people in your community tell you to pray about it. Okay. And it's been very difficult in this community over the years to create understanding that you can pray and seek help, right? And they're not mutually exclusive. And now you'll see a lot of houses of worship really focusing on letting people know that you can pray and you can have faith and you can rely on your faith while still seeking out support and help. Many patients of color suffer in silence, and many equate illness with weakness or emasculation. So I've even heard doctors that I've spoken to say that Black men don't complain. And I can't speak for all Black men or all Black people, but in my experience and hearing that enough times and then knowing it in my own, circles of relationship, it has some truth to it, that Black men don't complain. They're less likely to seek support because in some communities, seeking support and seeking help and being vulnerable is equated with weakness, okay? People of color face discrimination regularly, even at the doctor's office. Okay, newsflash, that shouldn't surprise anybody, but one of the studies that I read about talked about not just the person of color's experience in the doctor's office, but what does the person of color experience even well before that, when they're calling to make the appointment? Are there times that they're feeling there are microaggressions? Are there times that they're feeling assaulted in their interactions, even when they call to make the appointment? When they pull into the parking garage, what's the experience? When they get on the elevator with other people, what's their experience? Are they facing discrimination? When they get to the information desk? So all of these things and interactions that happen well before they get to the practitioner start to color their experience and start to color what they think about going to get medical treatment. And so that discrimination is a deterrent from them really establishing trust in these medical settings and hospital settings. And then there is just globally a lack of interpreters and cultural mediators to help patients and doctors connect. So obviously, if there are language barriers, that's going to be an issue, but also cultural mediators. So you'll hear people talk about cultural competency, right? And there's just not enough training around those issues. There are things in communities and in cultures that create nuances in how people move, what they think, what they believe. And if that cultural competency is not there and there aren't mediators available in the healthcare setting, sometimes that can result in a negative experience for people of color. And then historical experience. Okay, hopefully, and we don't dwell on this, but we have to acknowledge it, right? That specifically in communities of color, there is a distrust, a historical distrust of the medical community, okay? And that is not out of the blue, it is substantiated with fact, right? In historical instances, there has been a history of mistreatment by medical establishments. There have been, inhumane experiments on groups of color. There are forced sterilizations and the withholding of treatment, right? And we can all Google and look up some of these examples to know that when these things happen, and they didn't all happen, thousands of years ago. These things happened maybe 2 and 3 and 1 generation ago. And so these are the stories that are passed down in families that lead to distrust of the medical community. And one representative of that is the fact that last November, only 42% of Black Americans were willing to participate in getting the COVID vaccine. In the African American community has been one of the hardest to educate and persuade around the vaccine, because there's just a distrust historically of medical professionals. And that's so unfortunate, so unfortunate. And then this is important to know, and people may not know this, but people of color are consistently undertreated for pain relative to white patients, okay? I mean, who would think that, right? And that is because studies show that 50% or more of medical students and residents hold false belief, okay? Hold unconscious bias about biological differences between people of color and white patients. They specifically have surveyed and found out that these medical professionals literally feel like people of color can tolerate an increased amount of pain, or that their nerve endings are different. And because of that, it really affects how they treat the patient, what they prescribe for the patient, what level of service they render to the patient. And this is just preposterous, right? It is preposterous, but it is a fact. So if 50% of medical students believe that, then who are we putting into our healthcare facilities? Who are we training to be the next generation of medical professionals? And then what experience do people of color have when they are seen by these professionals, right? According to Centers for Disease Control, Black women are 4 times more likely to die from pregnancy-related deaths than white women, okay? And many studies show that that is considered a lack of being heard, a lack of being believed when symptoms and issues are reported. And then another study found that 53% of Muslim women delayed seeking medical care because of modesty concerns. And I know in my previous work that I've experienced that with Orthodox Jewish community as well, where their modesty concerns aren't respected and aren't observed in healthcare settings. And because of that, they don't receive the treatment that they need to be successful. And so what I want to say is that organizations like the Myositis Association and healthcare professionals have to do this work. It's a must. It's not optional. We cannot put forward a mission that says that we want to get to a cure and we want to change quality of life, but leave people, human beings behind in this conversation. And so we are all charged to acknowledge these issues, to act on them, and then to allow them and to infuse them to set the tone in our work, okay? Many of us are looking for and then dedicating financial and informational resources in our work and looking at who we can partner, with whom we can partner to leverage resources, okay? We are solidifying our commitment to equity and to this work. And we want to identify where the disparities lie. We're talking to patient communities so that we can come up with action steps to close the gap. And realistically, we are confronting the isms within our own organizations. Right? We have to acknowledge that this is not an external issue. We all have participated in creating this systemic system of disinclusion, okay? And so the first thing is to acknowledge it and then to put forward the good work that will resolve it. And specifically in relating to people of color, you can't do the work without them, okay? And so that means that we have to create spaces for people of color, and I'm sure Jen will say the same thing for people in her community, to come in and to support the work, to inform the work, and ultimately to lead the work, okay? And so here are a few ways that people of color can advocate. If you feel vulnerable or discriminated against in your healthcare journey, right? Trust your gut, okay? Trust your gut. If it doesn't feel right, and this is for anyone, whether it's, equity issue or you're just a patient who seeks out medical care and you don't feel quite right, trust your gut, okay? Do you feel dismissed? Do you feel like you were heard or were you talked over, right? Do you feel judged? If you suspect any kind of dismissiveness or bias, or you just don't feel respected, don't hesitate, move to someone else, okay? It is important that you are in an environment where you feel comfortable and you feel that it's a good fit. And then you have one more responsibility, right? You have to file a formal complaint if and when you are the victim of something egregious, right? Why? Because you have a responsibility to the people who come behind you, okay? So if it's egregious and if it's abusive, then you must file a formal complaint. And all the studies show in hospital settings, specifically, that when people of color advocate for themselves, it improves their health outcomes. The hospital administrators are looking to resolve these issues. So if you don't speak up, they don't have the opportunity to be informed by your experience, okay? Prioritize yourself. This is easier said than done. Gosh, I'm sitting here on like 2 hours of sleep right now saying this, right? But in communities of color, people are often trained to put the needs of other people before their own, okay? We take care of our family members, and this is not exclusive to communities of color, but specifically in communities of color and immigrant communities. And, it's very, there's a heavy load of familial responsibility, right? And not just our immediate family, we take care of the community, right? And so we get into a rut of making sure that we're taking care of everyone else and we are doing what we need to do for everyone else. And we're letting the things and the needs in our own lives and our own healthcare slide. So we have to advocate for ourselves by learning how to prioritize our health and prioritize ourselves. And then understand that genetics are indeed in play. Genetics are in play. There's so many diseases, chronic illnesses that are related specifically to your genetics and to your cultural background, right? That there are diseases that manifest differently depending on your genetics. And it's important to understand that. Genetics play a role in some conditions, and it may require different care for people of color, okay? I had a situation with my own healthcare provider where she printed an order for me to go get lab work. And for the first time, I think you might have seen this, Jen. For the first time, I looked at my information on the form, and where it had race, she had written multiple. And I was like, well, who said, who informed that? Like, that's not, I don't identify as multiple, right? And to me, that was problematic because I need to be identified as who I am, so that if there are illnesses or variances or nuances that affect African-American women differently, that it is acknowledged in my medical chart. Okay, so don't make assumptions. I need you to ask me and to make sure that my genetics play a role in how you evaluate what's going on with me. And on that note, it's okay to ask. It is okay to ask. If you have a medical professional with whom you're vulnerable, and think about it. These are people who see you, unclothed, who know what's going on inside of you, who know the inner workings of your body. And if you can't ask them a simple question without it being an issue, that's probably the issue. So it's totally okay to ask, if you are identified as a person of color, to ask your treating physician, how will you manage my condition as a person of color? And they may say that your condition has no variances because you're a person of color, and that's fine, but it's okay to ask that question. Look for representation. So this is a tricky one because obviously the ultimate goal is to get the best possible health care and outcome for your condition, regardless of anyone's race, ethnicity, how they identify, what their lifestyles are, who they are. It should not matter, right? None of that should matter. The goal is to get the best possible health outcome. But with where we are as a society now, it is completely okay that you do what makes you most comfortable. And in that case, for people of color, that may include considering the benefits of a same race or same ethnicity doctor. But what I would always say is that I would weigh the benefits of that with the benefits of being with someone who has the most expertise and resources. Because at the end of the day, I want the best possible care, and I don't care who I get. They could be green, purple, yellow, or whatever the case is. I want the best possible care. While we do this work to make sure that everyone can receive the best possible outcomes from anyone. And then complete the survey. So if your hospital, your medical practice gives you a survey, they are wanting this data about your experiences so that they can inform their decisions, where they can inform where they'll invest. What are the areas of work where they want to have solutions, where they want to improve their service model, and they can't do that if they don't have feedback from you. So fill out surveys whenever possible. And so that's my spiel on people of color. Obviously, this is not the only disenfranchised group. There are many people who experience issues with health equity, and our goal is to make sure that we don't leave anyone behind as we do this hard work in all of these communities. And with that, I will turn it over to Jen.
So I'm going to start out speaking just like Chrissy did about, you know, as she said, healthcare professionals are wanting to, they want to care. They went into that profession for a reason. However, they're just like everyone else. They're human. So just like they could have racial biases, they can also be just biased in terms of gender or gender expression, homophobic in some way, or even if they're not biased in that way, they just are uneducated. So a word that I use here is affirming. And affirming care recognizes the impact of sexual orientation and or gender on someone's life. Just recognizing that is one piece of that. And then the other piece is using that recognition to give appropriate care. So affirming care really applies to everybody, but when we're talking about people who are LGBTQIA+, we're talking about the care really understanding how they identify impacts their life and that it has a big impact. So it's especially important, I want to say, in mental health care. So if you see a dentist maybe once or twice a year, and they're not super educated on, you know, LGBTQIA issues, or they maybe have some bias, it's not going to have as big of an impact. But when you're doing therapy with somebody who's hearing about your life and you're working on things every week, if that person isn't educated, if they're not affirming, if they're not understanding of the way that you live your life or who you are, that's not going to be a beneficial experience for someone. It's not going to be good healthcare. So that's especially an area where we need professionals who are LGBTQIA literate, that they have some education, that they understand the experience, at least to some extent. I also think that finding those healthcare providers, it's not just the doctors, right? It's the mental health care providers, it's the nurses, it's the person at the front desk. So as a person who might be trans or non-binary, even just going to that person and they're not understanding or literate or they're discriminatory, that can be the end of the healthcare for that person. They're like, nope, I'm not going back because that was such a horrible experience. So that's an area where we need to be aware that it's not just the healthcare providers in the doctor, for example, it's everybody in the healthcare system, that if they're not affirming or they're not LGBTQIA literate, that's going to have a very negative impact on a patient. So we're going to go on to the next slide. So there's obviously a spectrum of discrimination. And I will say that I'm probably on the more privileged side. I am feminine presenting. When I'm out in the world without my wife, many people will assume that I am straight. And, you know, there's sort of a spectrum of how discriminated against people are. And I would say that, you know, trans, intersex, and non-binary individuals, there is just a lack of healthcare professionals who are trained or even willing to treat those patients. You will hear many stories of people who can't even find a general doctor to treat them because they're not educated on the issues that impact them. So imagine trying to find a specialist or somebody who's trained about a specific illness. It's very difficult. So there are significant health disparities, and that is especially high in mental health disorders, but poor health comes overall. And we have to have, even minimal expectations of just healthcare providers using the correct pronouns for someone. You can imagine how horrible that would feel to just not even have your gender affirmed by the person that you're speaking to, making that mistake over and over. One time you can, correct that. But unfortunately, when you're, dealing with people over and over and you're having incorrect pronoun usage, that's just not acceptable. So we need to expect that as absolutely the minimum of care. Healthcare professionals who understand hormone therapy and gender affirming surgeries, there is a lack of curriculum in medical school devoted to those issues. Healthcare providers do not know that information, and that has a horrible impact on the healthcare that people are receiving, because in order to give preventative care, for example, cancer screenings, healthcare providers have to understand the impact that those hormone therapies will have. They have to be able to understand the things that that person is going through. And unfortunately, most healthcare providers do not have that information. So that's something that needs to change. And as of now, it has very significant impacts on the health disparities that we see for people who are trans, intersex, and non-binary. So heteronormativity. We live in a world where people assume that someone is straight. They assume that, if you speak to somebody on the phone, you'll guess at their gender. You might notice that Chrissy and I both have our pronouns right here on the screen. Especially if you live in the South, you get a lot of ma'am and sir, and there is assumptions that are made at all times, and that happens in healthcare as well. So, for someone who's maybe more masculine presenting, but is in fact a woman, there can be misgendering, for example, and those things can really have a big impact. And having to come out or address this misgendering or incorrect pronouns, it can be very stressful. We talk about coming out as a one-time thing. It is not a one-time thing. It is a constant thing a lot of the time. Having to come out can be very uncomfortable, and even in some cases unsafe. So assumptions being made, and then you have to come out to your healthcare provider, that could feel unsafe, that then they're going to say, well, now I can't see you, or even horrible things said to them. So it cannot feel like it's an okay thing to do. And some people will just avoid it in order to not have to deal with that discomfort. So that affects healthcare as well. So go on to the next slide. So people also experience assumptions about sexually transmitted infections or promiscuity, just assumptions that people who are LGBTQIA plus are more likely to have those infections or are more likely to be promiscuous. Those things can impact how a healthcare provider will interact with someone. Assuming that transgender patients want or have had gender affirming surgery, that is not true. Many choose not to, and that assumption can be hurtful or not helpful in their healthcare. I think that as we move along with, there was a time when being gay was considered a mental health disorder. Being trans was considered a mental health disorder. We're moving forward, things are changing, but as things change, people are not educated. So I think that unfortunately there is bias about non-binary individuals. A healthcare provider might think, oh, that's just a trend that the young people are doing, and not understand that it's a valid identity. Discrimination, or even just disregarding bisexuality or pansexuality, the bi erasure, erasure of pansexual people. I had an experience where a healthcare provider, I had previously been married to a man. I'm now married to a woman. And the healthcare provider said, oh, so I'll just put lesbian on your chart. And I was like, no, that's not how that works. You continue to be, bisexual or pansexual. It's not based on who your, current partner is. And that can lead to, if she hadn't said anything, perhaps making that assumption and not giving me the right healthcare based on that assumption. For example, birth control. If my current partner was a woman and then I went to a male partner and she hadn't given me birth control, or given me the option of birth control, that could have been an issue. So those assumptions can be damaging as well. Go on to the next slide. So I would say that all of these things can lead to patients avoiding doctors, worse health outcomes, symptoms being ignored or not listened to. This is a lot of the same things that Chrissy was talking about. Insurance sometimes doesn't cover medically necessary procedures because they're put into a category as being sex specific or cosmetic or experimental. So even once somebody gets to the point of getting the care that they need, they may be denied insurance for those things. They may be denied coverage. And then the last thing that I wanted to talk about with this is that those who are the most marginalized will receive no healthcare or have worse healthcare outcomes. So there is an overlap of gender, sexuality, fat phobia, race, ageism, all of these things put together so that patients can feel alienated from care. So when we're talking about privilege, a Black trans patient is probably going to be the most alienated from care and possibly have the worst outcomes versus someone who is cisgendered white male, for example. So all of these different areas of privilege and not privilege are going to overlap together and affect someone getting the care that they need. And we have to recognize that when we're advocating for people, we need to be advocating the most for those who are the most marginalized. So if we advocate for Black trans people, we're advocating for everybody, but they're going to have the worst time finding somebody who can treat them. So we need to advocate and say, this is the area that we're going to put our efforts into, because if they can get care, everyone can get care. And if they can find someone who can treat them appropriately, that person is a superstar and that person gets it and they have the education. So if they've got it, everybody's going to get it. So that's where we're looking to push for the health equity in that area. So I'm going to also talk about in the next slide how we can advocate for ourselves, and this applies to everyone, but obviously there's some specifics that I'm going to talk about with the LGBTQIA+ community. So getting a reference to a doctor from someone who is in your marginalized group. So this may be, let's say someone who is a person of color is in a group, a support group for people of color. They can say, hey, I'm really having trouble finding a specialist in dermatology to help me. Has anybody had experience with somebody who really understands like how to identify my skin condition on darker skin? Because unfortunately, not everybody's educated about that, right? And it's the same thing for somebody who is LGBTQIA+. They may say, if they can find somebody who's had experience with a doctor who is educated, who is LGBTQIA friendly, that's going to be helpful, because that person's going to say, oh, you had a good experience there? That's helpful for me. Maybe I'll have a good experience there. And that kind of personal introduction or personal knowledge is going to make a huge difference in someone saying, okay, I feel comfortable going to this doctor. I think I'm going to have a better experience. Or I feel comfortable, reaching out to this therapist. I think I'm going to have a better experience with them, because clearly they know how to treat these people. And also even asking by phone. So calling an office and saying, hey, does your, does this provider have LGBTQIA+ patients? Do they have experience with this? Are they comfortable seeing, people like me? So, trying to finding that affirming care by doing those things. Ask to speak to the provider before the visit. As you might imagine, having a conversation while you're in that gown or in the stirrups, for example, is not comfortable. Let's normalize having a conversation ahead of time with your provider so that you can share all the information that you need to share while you're a little bit more comfortable. This is especially important when we're talking about trauma-informed care. So if someone has had trauma, they've had bad experience in the past with a healthcare provider, sexual abuse, physical abuse, that is going to be a very uncomfortable visit for them if they go straight in to the visit. Let's have that time to speak to the doctor, to speak to the provider, to say that, I know this is what I need. Can you walk me through the appointment? When we go through the appointment, can you tell me exactly what you're going to do? And this could be with a dentist, this could be with a doctor, a gynecologist, any of those things, to say, this is what I need from you when we go into the appointment. Can you have a same-sex nurse in there with me? That would make me feel more comfortable. Could you leave the door open during this part of the exam? Or, so you can advocate yourself in that experience and in that time before the actual appointment in a way that you can't once you're in the appointment. That might mean bringing a friend or family member to support you. Maybe they can take notes for you. Sometimes in the appointment, if you're anxious or nervous, you may not feel like you can take in any information. So having that person with you just to take notes may be a huge thing. And I will mention at that point that that's one of the places where sometimes LGBTQIA people don't have the support. They may have lost family in their coming out experience. They may not have that family support. That can impact maybe some financial support. If they're a young adult, they may not have that, but also potentially not having the support of a family member to pick you up from an appointment or go with you, or things like that. So that's another place where that disparity can come in, that we don't always think about. But if you do, a friend, someone, that can be very helpful. So this was one that I wasn't aware of, that in doing some research for this presentation, it's very important that trans individuals have an anatomical inventory recorded in their medical record, because as uncomfortable and awkward as that can be, not for your dentist, but for some medical care, it's going to facilitate appropriate care if they know exactly what anatomical things you have going on. So that's an important piece to have in your medical record, so the doctors know exactly how they're giving you care. And we all need to advocate for medical schools, medical organizations, hospitals, et cetera, to become more educated and accepting of LGBTQIA+ individuals, and to say that substandard care is not acceptable, that it's not okay to say that, well, I'm a healthcare provider. It doesn't matter if I give care to these people. I can give care to someone else. No, everybody, every healthcare professional needs to be educated and needs to be able to give care, adequate care, affirming care to people who are people of color, who are LGBTQIA. It's not acceptable anymore. Our world is moving in a direction where that's no longer acceptable. And that's what we have to advocate, is saying, this is what we expect. We expect you to be able to care for people who are, in the rainbow mafia, as the kids are saying. All right, I'm done with that slide. I have some resources here. I know that it doesn't look like there are very many of them, but the GLMA, the provider directory there is the one that everyone will send you to. That's the most comprehensive. So, and it's a pretty easy thing to find. The National Queer and Trans Therapists of Color Network is a great resource because it's very specific. And then the Human Rights Campaign has a whole list of patient resources. So even if you just go there, they're actually going to have the GLMA link there. They're going to have articles on, how to speak to your healthcare professional, how to come out, what to ask a healthcare professional to get a sense of if they're going to be affirming for you, things like that. So they have a lot of great resources on their website.
So before we close, I want to ask you, because we're winding down on time, to go ahead and put any questions you might have in the Q&A or the chat box so that we can address them. But we want to talk about the role of allyship, because this is not a conversation that can be limited to people who belong to these communities that are marginalized, right? It will take people who don't have the same experience, who have a baseline experience, who have an affirming experience, who don't experience these inequities to help make the change. And so we wanted to talk today a little bit about allyship, okay? Because there's certainly a role for allies in what we're discussing. And an ally is somebody who may not be a member of this underrepresented or even underserved group, but who takes action to support the cause, okay? It requires privilege in many cases to make change. And so we need people who are willing to leverage their privilege as active allies to help others, to help others, to help others become successful in being humanized once again, okay? And so an ally does the below thing. They recognize and acknowledge that there is systemic health inequity, okay? They're empowered to evaluate it and to step up and advocate for change. They understand that they have a role, and in many cases, a leading role, right? To be advocates and allies of these communities and to lead these conversations. All the while knowing that there's a difference between allyship and saviorism. So that's the difference. I love this here that demarcates it into I stand with you and I'm here to help you, here to fight with you, versus I'm here I am, to save the day, right? Because that approach is not often well received in these communities, right? Because it can be patronizing. It can seem disingenuous, right? So the genuine thing is, listen, I may not have experienced this. I may not even truly understand everything that you experience, but what I can tell you is I know what it should be, and I'm here to stand with you until we can get to that point. And so that is what these communities would request of allies. And I put here that imperfect conversations are better than silence. We have to be willing to talk about these things, as uncomfortable as it may be. Specifically, if you're not someone who has to experience the inequities and you're not somebody, it's very easy to push it to the side and act like it doesn't exist. But if we don't have the conversations, then this will not get better. It will not get better. And we have to understand that the conversations are hard. They may be bumpy. They may not be appropriate initially, but we have to teach one another how to communicate about these issues so that we can all have a space of comfort. Jen, do you have anything else before I see what we have in the chat or the question and answer box?
I was just going to say, if people have heard the term amplifying, so instead of advocating sort of as yourself, it's sort of the idea that you're amplifying the experience and the voices of those who are experiencing the inequity. So instead of saying, this is my idea, right? Or, parroting something that you've heard, it's saying, no, did you hear about this person who is advocating? Amplifying that voice as someone who isn't in that marginalized group and saying, I care about this too, even though it's not my issue. I'm going to amplify that voice. I'm going to amplify that experience. Hey, my friend had this experience where she, saw this healthcare provider, and it was a really bad experience because the healthcare provider doesn't treat people who are trans. Can we talk about that in a way that to make sure that maybe how to do that next time, or things like that. So
at this point, we will open it up for questions in the chat or the Q&A box. So let's see what we have here. Hello, thank you for speaking to the myositis community. I'm cis female, 40 years old, Hispanic with DMPM. I live in Florida since 2019. I've seen huge health disparity in healthcare for females, ethnic communities, and people with rare diseases, long wait times for appointments, lack of attention from care teams, and discontinued clinical trials and research. First part of my question is, should I seek help from a patient advocate? If so, who in my area? So I would say absolutely, right? Because there are programs, there are people positioned specifically as advocates to help you go in and to seek change, right? At Myositis Association, we refer at this point to different advocacy organizations. We're in partnership with some very strongly, where we refer patients who are having these difficulties so that they can get better outcomes. So if you would like, please feel free to email us at tma@myascitis.org, and we will help direct you to a patient advocate. But it doesn't necessarily even have to be a healthcare advocate. So in your community, if you're in a community of color, you can seek support and advocacy from your faith community, from your civic community, from, from different peer groups where you move and exist. As Jen said, sometimes it can be as easy as just bringing a witness, a third party, a friend or a family member to come, and you'll see that in isolation, sometimes it's easier to treat people in ways that we aren't conscious about, but in group settings, it can be a little bit different. Jen, you have anything?
I think in her question, she also said that sometimes pushing back has led to negative outcomes. And, unfortunately, that can happen in any of these marginalized groups. I'm very sorry that that has happened to you, and it's unacceptable. So I would, if there is a way to report that to someone, if there's an HR representative, sometimes if it's in a hospital setting, there can be patient advocates, or there can be someplace that you can report that to. That can be very helpful. So I would say for sure, it's unfortunate, but yes, some people don't do well with being called out on their bad behavior. And that is true in healthcare as well. So yes, we say, please push back, say this isn't acceptable care, but we absolutely understand that that doesn't mean that you're going to get the care that you deserve, or that that's going to make people act better. Unfortunately, it doesn't always make people act better. So yes, sometimes you have to go to a, higher up in order to try to rectify that.
And it's difficult, specifically in rare disease, where there are only, this many clinicians who treat effectively and have experience with myositis, right? And so you don't necessarily even have the privilege, right? Because your rare disease, eliminates a whole nother level of privilege. You don't have the privilege to always be selective, which is so unfortunate. But what we can't do, especially living with chronic illness, is settle in an environment where we'd be flagged as a troublesome patient or a problem patient. Because
Right.
if they're flagging you and you're cognizant of that, then it's going to amplify your stress level. It's going to amplify, some of the other things that you experience, and it's just not a good fit. So that's a trust your gut thing. It's hard because we know that there are limited areas of, people who have the expertise that are needed in this field, but you cannot subject yourself to abuse on top of the illness that you're facing and living with. So that would be.
Yeah. And also in her question, she mentioned, someone had recommended telehealth with maybe a specialist. And she said, well, I can't do telehealth with everything. Absolutely understand that. But one thing I would say is sometimes if you can find one provider who is on your side, who gets it, they can then advocate for you with other providers. Mm-hmm. So unfortunately, sometimes that's who a healthcare provider will listen to. So if you can get one doctor to be on your side, to understand your issues, to really get it, then they can hopefully connect you or connect with your other providers and say, this is what I saw, I've been speaking to this patient. Here's what I see. And unfortunately, they might listen to that person a lot more than they're going to listen to you. And that's not the way it should be. But sometimes just having one person in your corner can make a huge difference. So that might be the role of telehealth for you.
I don't see any additional questions, just some comments about the presentation being enlightening and not what was expected, but glad they attended, joined late, but so pleased that she did. Much needed conversation, forward-thinking presentation on this topic. So thank you for those comments. We very much appreciate them. And before we go, with no other questions, I want to thank Jennifer for giving of her time and her insight and her experiences to share with us today. I think we're so fortunate to have been informed by what she brings to the table in this presentation.
Thank you.
Today. So thank you so much, my friend. I'm so glad to have you and to be able to lean on you and tap you and call you when needed, and to have you represent all of the communities to which you belong. Because as I stated, we need to bring in people with lived experience in order to lead the work.
Yeah.
So thank you. And thank you all for joining our presentation today. We wish you a wonderful rest of the conference.
Thank you, everybody.